Good. I've got a bunch of questions here. I guess I can't get to them all. Can you talk about hospitals in underserved communities? How are mergers, payment changes affecting them? And is there any hopeful strategy for them?
It's probably more in your space, but I'm happy to take it.
No, go at.
Okay,
we don't rate a lot of the.
Because they don't really.
Yeah.
So, there are a lot of hospitals in a lot of locations that are going to either close or become freestanding emergency rooms or something akin to that, simply because there's just not going to be enough money in the system to sustain a full-blown hospital. They will, I think there used to be 58 rural hospitals, one for each county in the state of Iowa, without trying to offend anyone from Iowa, believe me. And part of the reason for that was Senator Grassley's generosity, that he made sure they all stayed open. And, there was big defense of rural hospitals when he was in Senate Finance. And it was a great time for the for-profits. It was a great time for the rural communities. But unfortunately, a lot of hospitals were built because there was excess margin in that business. And there were monopolists, and now there's not. So I think what you're going to see is, the definition of an underserved community is, unfortunately, they're going to be underserved for some time to come. One of the programs that HCA has actually been using quite effectively has been a transfer program where the local primary care physician retains control over the patient, is connected via telemedicine and systems, technology, to maintain a hand in treating and control over that patient, being part of the decision-making process when that patient is transferred to a more urban center of excellence for more complex care. And then the patient is returned back to the community. And they found that to be very successful. It builds a good relationship with the local community. The patient outcomes are good, and the costs are controlled. So they are using this wherever they can to address the issue of underserved communities.
Yeah, I'm sorry. I was thinking more inner-city safety net hospitals, but
well, they're not so dissimilar.
Yeah, but I agree with you. I think when you look at the rural hospitals, the other thing there is just the demographics are working against them as well.
Population's dropping like
population's moving into urban centers, and generally speaking, I think when you see a lot of the, if you're looking at Becker's and you see some of the critical access hospitals that are filing for bankruptcy, what do they have? Inpatient stay of 4 patients. You can't support it.
Yeah, sustain it.
Exactly. And so I think that, like you said, the ability with telehealth, with improved IT, you can do those consults. And really, I think what you're going to see over time is some of those critical access hospitals, depending on their demographics, are going to turn into essentially emergency rooms where they can transport patients. I agree with you.
Yeah. Sheryl, this question here. What do you see in the coming out of the Duke LifePoint joint venture?
It's been a very opaque.
You should probably tell people a little bit about that.
So a number of years ago, LifePoint was having a lot of trouble maintaining decent quality of care out of a particularly large hospital acquisition they made in Danville, Virginia, and made a commitment to dramatically improve the quality of care that they delivered and stability of their hospital system and their acquisitions going forward, and was looking for a partner to help them to move forward to their credit, move forward on that agenda. And so they contracted through a joint venture with Duke, which in that Danville, Virginia, on the North Carolina border was a perfect partner for them, since they own 5 hospitals right along the highway route. And they did, in fact, dramatically turn around the Danville Hospital and improve the quality of care. And since then, they've expanded that joint venture to, and they use the Duke LifePoint, which carries a great brand of quality of care, to start an outpost in a new market. So, for example, in Marquette, the first acquisition that they made was via Duke LifePoint, and then they ring it around with other facilities with either a LifePoint branded hospital or a Duke LifePoint branded hospital or physician practice or ancillary service. And so what I think will come out of this is, the problem that I have with it is, we have no idea how much money Duke is making off of this. We have no idea whether it's actually accretive to LifePoint's profits in a meaningful way, except to the extent that they consolidate results, which must mean that they have a 51% claim on profits, but maybe not. So, because there are some accounting rules that would allow them to consolidate without that. So I don't like things that I can't see. So I'm a little cynical about that. But having said it, it's been tremendously successful because they're bringing to smaller cities and other smaller marketplaces an approach to quality of care coming from Duke that seems to be working, seems to be generating better outcomes. Their readmission performance actually is better than Tenet or HCA's, according to the most recent data, which was kind of surprising. They'll have a much smaller, in fact, they'll actually get a slight increase overall on average for all of their facilities. Except at the Duke LifePoint ones, there the readmissions are still high because they're relatively new acquisitions. So, and they're working on those. They're making some progress with that. And I think what ultimately comes out of that is that you see more hospitals being branded as Duke LifePoint through this acquisition strategy, still a limited number, and then the rest of them will be LifePoint hospitals.
Thanks. And do you see interest in other companies of doing similar things? Or is it too early?
Well, I think it's probably too late, actually. No, I mean, in terms of the notion of having to partner with someone to improve your quality without being able to do it internally is something that neither Tenet nor HCA needs because they started their quality improvement programs a long time ago. The one who could probably use a little bit of help with some of it is Community. They've got other issues right now that they're dealing with. So they're not in a position to do that.
Okay, thanks. Well, regretfully, we've run out of time. And time went quickly. And I want to thank the panelists who did a really terrific job. I want to thank the JKTG Foundation for funding the event, and also thank the USC Schaefer Center and its staff and consultants for putting this on. And particularly want to thank Alwyn Castle, who worked with me for many years at HSC, and a number of things does help out USC Schaefer as a consultant. Thank you very much.